Yep. So this is the paper which represents the position up to the end of July, the current year. As usual, I'll take the paper to it, but just about some of the key salient headlines. So it's in the paper, in-month loss over 733k in month 4, which is an improvement. So year to date, we've been seeing about 1.3 month loss. So that's a quite significant improvement in month, largely driven by increased income associated with activity. And it was also 0.2 million better than planned. So good signals there. I guess being pragmatic, it's still 0.4 million off plan year to date, and we have a cumulative deficit year to date of 4.3 million. We do expect the efficiency program impact to start playing through more significantly in the second half of the year. And that obviously will improve the run rate, but as I've referenced before, probably worth reiterating here, there are still a significant number of risks to delivery of a plan to break even. Obviously, delivery of the efficiency plan itself is not least amongst those. We still have escalation capacity open on an ongoing basis at the moment, which it wasn't budgeted to be. So that's about 250,000 a month, which we weren't expecting. Cost of RTT recovery in terms of premium costs not covered by increased ERF payments is still a significant issue for us. Payment for ERF activity itself, there is still a lack of clarity nationally around how and when we will get paid for that in the current year. So that's a significant risk, but in terms of the INE and the cash position. And then, as referenced previously, some of the ways in which our activity is counted around SDEC present some challenges for us. So not insignificant challenges, but we still continue to forecast a break-even position at year end. We're actually due to get our month 5 numbers today, so I will know today whether there's any evolution of that story. We also have a meeting this afternoon with NHSC about the system financial position, and it's probably worth referencing here that the ICS is going to be more materially than us collectively off plan, 8 million year to date off plan as a system. As we talked about here before, our position nationally in terms of interventions is judged at system level. So I think if there's a continuation of that level of adverse variance to plan, then the things we've talked about here before around intervention, triple off, etc., still remain clear of present risks. Also, perhaps today, I'm not expecting necessarily that will be something that will follow today's conversation, but I think continuation of those kind of numbers will present risk for us as a system.
Ian. I just didn't hear you. Was 18 or 80? 8.
Variance.
Yeah, I was in the benefit of attending it as well. I think there's 2 things for me, Jonathan. I'm sure the board will talk to the board about in terms of the challenge we face with our efficiency programme, about how confident you're feeling at this point, and I hear about the journey of improvement and the journey that's going on the table. But then you mentioned at the end about the impact of the wider system, and I wonder whether you could just talk just for a minute about how concerned you might be about triple lock or any other measure coming at us from something that isn't in our control.
Yeah. Okay. So I guess taking the forward question there, we talked about a PIC. We've got an efficiency target for this year, £24 million. Formally, at the moment, we have identified those schemes which we expect to deliver to the value of about 18 million. So about 6 million short. We do have a number of further schemes which are being developed, worked up, not least amongst those around the workforce and theatres. We do expect that to have some impact. We're also working closely with all the divisions around on a run rate basis. We can help reduce some of their key areas of spend. Orca is one of our key challenge areas. They've got significant premium costs and staffing at the moment, which we're going to help them with. So I do think we have the opportunities there to improve the run rate and get closer, if not to the efficiency target we require.
Can I just ask one thing on that point then? So there's people that say, well, we're trying to deliver more care and more people to the right constitutional targets. Why are we trying to save money? Joe talked about, said a bit of governance yesterday. And you talked, Joe, didn't you, about the fact that because you still see ways we can be more efficient. So, John, I think
the additional work we're doing is to a large extent driving some of the positive messages we're giving around income. So I think that's, there's a clear correlation there. we're paying a really clear focus around making sure we understand the cost of that activity and it delivers a margin wherever possible. In some cases it doesn't, and we're having a conversation with the region around those premium costs, how we might be supporting those potentially. In terms of those risks around implications of triple lock, etc., there's an opportunity risk that affects in reality what's playing out in other systems. As triple lock itself means that you'll have regulatory and system presence on things like your vacancy panel, your discretionary spend panel around how you spend your non-pay resource. Having sat in on the systems monitoring here, that means you may not be able to take the decisions you want to around key investments and decisions. So there's risk there. There's also risk around effectively the challenge because there will be investigation and intervention in some cases, which means that further impacts may follow. So it's not somewhere where we want to be. I don't think we'll end up there as a trust at this present point in time. Conversations with system partners lend itself to belief that they will improve as well. So I think at the moment it's a positive news story around hope there, but clearly the numbers themselves are the key thing. So there's very little.
I think, Chair, I'll bring it up later in the audit. There's a small paper there on the update in the committee, but we keep revisiting the issue of this, the risk of the system, what exposure we have to the system if we perform well, but the rest of the system doesn't. Perhaps we can return to that later if we've got time. Yeah, I'm a little bit concerned about that.
Yeah, I mean, the headline message there is the performance is judged as a system. So if the system goes into triple lock, etc., we all go in. There is some conversation nationally around whether parts of that system that maybe perform better than their peers locally, some of the impact may be alleviated marginally, but it is likely to be marginal rather than.
And you'd like to think if the system didn't miss its target, that the regulator would be discerning in which bits of the system causes the problem. So we shouldn't be adversely affected even if the system is deemed as in favour.
I agree with that. But I would also say, I guess, if you've got a position opponent, we are adverse to plan and a deficit ourselves. So we are not squeakily.
No. Well, but it's cyclical, isn't it? Because we're working extremely hard to balance, and I heard you say that we are likely to come out of balance.
Still on the plan at the moment.
So the new environment we're operating in is that we work extremely hard to get there, and then we realise the rest of the system around us is perhaps not. So now we've got to have one eye on the system, which is why it was invented, why it was created that way. So we were compelled to work with partners. I just don't think that's a system we've quite figured it out yet. So the implications of letting another part of the system overrun deficit.
Yeah, I mean, there's risks there. We are having lots of collective meetings, both in the finance community and beyond, around how do we manage the position, understand where we can work together to deliver greater efficiency and productivity, and mitigate some of the risks that people want to that.
Any other questions or comments on this report? I think it's a very ongoing theme, so I think it's a good, clear report. Thank you very much, Jonathan. Workforce report, Louise, if you want to pick out any highlights.
Thank you. So the table on page two just takes us through the KPIs for workforce. The ones that I just wanted to pick out were vacancy rate continues to reduce. We're down to 6%. We've reached our target for turnover at 12.5%. That's been a huge journey over the past 18 months. I would say that we've been monitoring through Workforce Committee. So it's good that we've met that target now. We're going to continue to keep doing the work on that retention piece. Our focus at the moment really is on that temporary staffing usage. So having a look at bank spend, bank usage. Are we using bank where we absolutely need to be using them? And putting some workforce efficiencies around that. Sickness absence is another area of focus for us, seems to be creeping up. So we're looking at putting back in some governance around making sure we are addressing those areas with long-term absence, giving them additional support and training and education and get back to work. The other pieces in here are around the induction and onboarding improvements that we've been working on. So that's all part of our workforce strategy, making sure that people who are starting in our organisation stay in our organisation. So making sure that managers have got all the tools and information that they need to be able to manage from day one that they come into the organisation. And that's to support the MK Way programme that we've got going on as well at the moment. Our Protect and Reflect event as well starts at the end of September, just to highlight that. So we are now entering another round of staff survey. So that runs and opens for a period of 8 weeks, and it will be.
Can I ask a question on the support workers? I know we know we understand pressures outside in terms of other employers and salaries that they're offering for these individuals. Salaries are very important. If we could recruit another 20 tomorrow, we would be on that journey. I'm trying to understand kind of, because the number of 92 vacancies is quite significant, and whether you think we've got enough drive behind trying to fulfil that requirement.
Yeah, so we've done a huge amount of work in trying to recruit those healthcare support workers, and we've worked with VLMK actually on some of our social media and pieces around what that role looks like. Not only is it hard to recruit, but it's hard to retain. Lots of people come into those roles and it's not what they thought it was going to be, but when they entered that role. So lots of people leave between that 6 to 12 months. So our churn is there as well. So it feels really difficult to get on top of that 92 number at the moment and getting to reduce that. I think the work that we're looking at on that job role, and we've got a specific group set up to look at the band 2 role as well, I think that will start having an impact as we go through, whether that is a band 2, whether it is a band 3, and what responsibility on the side. The other part of that is our education. So we've got the fundamentals of care programme for our band 2s, but it's about making sure that that's fit for purpose, that people feel supported when they're going then after that programme onto the wards. So it's actually a huge journey that we've been on over the last year, I think. And I think by the end of March, hopefully we'll start to see that we're cutting into some of those figures.
Just on that, I know in a couple of other areas, they look at the support work recruitment centrally, and then they get deployed out into, and that's causing issues with retention because it's not necessarily the area or expectation for some of the candidates. Is that something we're seeing here, or is it centrally?
So we do a little bit of a mix, to be honest. So we have some specific roles that go out like in outpatient areas, but generally I think the people that are coming through to apply to those roles for us are people that have not done that work before. So actually they apply to a role working on ward 18 to ward 19 isn't going to make a huge amount of difference to them from the background they're coming from. However, when we go through that process, the recruitment teams always have those conversations with them at interview and work out where they're going to be best suited. If they're not happy, we can also move them. We've got those vacancies at the moment, so actually those conversations with the ward sister are really important around how you're getting on. If this isn't the right environment for you, we'll do everything we can to make sure that it's a good fit before we, they make the decisions.
Questions on the work? Thank you very much. That's really clear. John, we feel we've already covered the new hospital programme because we did that earlier in the agenda under the chief exec's report, and John was, unless there's anything you specifically wanted.
It's just worth updating the board on where we're at with the strategic outline. Yes.
Oh, okay, yes. With any large project, you go through a process of strategic outline case, outline business case, and then full business case. The approvals are remarkably convoluted. And you will remember that the board signed off the strategic outline case. Oh gosh, beginning. And since then, it has been approved by the new hospital program team, and then by their investment committee, and now by region. It is now gone to what's called NCAT for approval, and NCAT is the the National Capital
Thinking Tina.
Approvals team.
Approvals team, probably not. Which is a committee joint between the NHS and Department of Health and Social Care. And then after that, it has its final voyage to what's called JIC, which is the Joint Investment Committee, which sits between the Department of Health and Social Care and the Treasury. Now they've both read the documents, they've both commented on the documents with a million queries that we probably already answered. And they both should finally approve it later this month. We have already, of course, started work on our outline business case. And to be fair to the meeting, they have funded the first £1.7 million of the outline business case. There's a lot to come. The total cost of writing the outline business case is going to be 10-12 million. But if we're funded up to date and we're expecting to see new funding really it will be required from probably the end of this month going forward. So all is moving in the right direction. All noises are still positive, as you can see, because they have released money for the enabling project. But this is a wonderful bureaucratic minefield. They keep asking us when we will get to the next hurdle, and I always go back and say, well, it depends how long we take to approve it, because if you like, we first submitted our outline case in November 2021, and we're finally getting to the end of approvals.
I think just to note, John, when you talk around the 10 million number to get to the OBC, and it's not that you'll start someone in the room being paid a huge amount of money. It's just it takes a lot of numbers and pieces of work that are required.
Absolutely. So this is for architectural team and the structural engineers and the planning advisors and the vertical transport advisors and environmental, and I can go on and on and on. The number of for a project this size, the number of specialists is astonishing.
I think this is not.
So when the new government came into power, there was an announcement of many infrastructure projects being suspended, if not cancelled. Has there been any talk of any risk to this programme?
So my hesitation is that the Secretary of State spoke to the Chief Executive community on Tuesday, where he said it was clear that the NHS needed to build new hospitals, and in particular, obviously, the focus on rack bank hospitals. But it was clear over and above rack banks that new hospitals were required. And the review that's being undertaken was in order to establish the appropriate timescales for these new hospitals and the budget that sits alongside them. So he didn't indicate that there was a cancellation of the new hospital programme, but a view that it needed to be set out in a deliverable way.
There will be almost certainly delay because the numbers of national builders who are able to take on whole hospital rebuilds is sort of £1.5 billion is on the fingers of one hand, and then they're not capable of taking on multiple projects at any one time. So we're talking about sort of like walks across the world. These are big, risky projects for contractors, and so just going through how many can you build at any one time does mean that the programme will be almost certainly put out. But there is still scope for the little projects, and we are still in the national scope of the little project squeezed in because we probably will get a regional builder rather than a national builder.
And John, is it the point of Mark's point? It's quite positive, isn't it, that we have done steps that we've done so far? Because if you're someone centrally looking at it, we've tipped ourselves into a.
Yes,
we've prepared these elements and spent money on.
Absolutely, and we have a track record of delivery, which is really important for the NHB because there are lots of hospitals who aspire but actually have little understanding of actually how difficult it will be to build these. So all the movement I think is really good for us. It is still a political hot potato.
Thank you very much. That's great. Moving on to statutory insurance items, we have the EDI annual report. Looking at yourself again, I think, Louise.
Thank you. So this is our annual ED&I report and action plans which came from our race equality scheme, disability equality scheme, gender pay gap and EDS2 that have been published this year. The action plans publication and publication of this report will satisfy our duty under the public sector. So here for information and highlights that I would just like to point out to the board. I think over the past year, our real focus has been on engagement, empowerment, and really setting up some of those networks as a core part of our staff voice here. We've got a new network that we set up this year, the Neurodiversity Network, which has been really well attended. Part of that is driving through some of our data to try and get that engagement from our workforce around what those action plans look like, how we can make those improvements over the next year, and how we can build our structure as well. Overall highlights from our performance, our gender pay gap has reduced our median. We've got lots of work to do with improving the experience of our colleagues that identify as having a disability. We've still got work to do, particularly with our BAME colleagues, on what that senior position recruitment looks like and improving our numbers in those. But also our action plans, we are very ambitious, as usual, in the workforce team, on what that is going to look like over the next 3 years. Part of the work that we're doing at the moment is going to support some of that. So our values-based recruitment that we're hoping to launch in Q3. So in the next few months, we'll support that, having our panels for reviewing decisions before they go through to disciplinaries is a part of that as well. So here, taken as read, but happy for questions.
It's really comprehensive. And of course, if you're one individual, it's very difficult in a sense not to kind of have positivity around all the good work. But if you're one individual in the organisation having one bad experience, that's not a good thing. And we all, I think, at board absolutely recognise that. But I think we have to acknowledge the work that Whole Trust, the people team, but also the wider team have done in all the parts that are trying to take this journey forward to improve it for the experience of everyone. I don't know if anyone's got any questions.
Being offline, to just understand how for staff to be able to participate in the networks that
Yeah.
The other privilege again of chairing the workforce, so I kind of get to see some of this in more depth, which is a good thing. You know, the quality delivery system, the EDS, and the 16 developing score.
Yeah.
Is that what would we have been expecting? A 16? Is that what we expected?
So we self-score ourselves on that. So EDS2 is a huge piece of work. It's not just staff, it's also patients and health inequalities as well. So it's multi-stranded. I think we probably are quite harsh on ourselves, to be honest, when we go through that scoring. But it's a huge document. I think it came to committee in, I think it was in May time when we went through that one. I think what our ambition is for the next 12 months really is to do a bit more in-depth work on EDS2. Having conversations with our partners and the system wide, I actually think we're doing really well in comparison. But it's just really around documenting all the good work that we're doing. That's the whole point of EDS2. So you've got it all in one document to show everything that you're doing with patients and with staff as well. And we just need to make sure that we're evidencing that, I think.
It's not more of an thank you. It's not an observation, not on the report itself. Quite interesting that we're in a hospital setting and all the NHS itself. We still use the term equality. For me, it's an interesting observation that really, I think we should be shifting the dial to say equity because you've made reasonable adjustments, particularly in an environment like this. So is it fully defined? Can Milton Keynes University Hospital be an example to say that we're creating an equitable environment for our staff and our patients? And shift that dial slightly. Do we have that ability to use that sort of terminology and really embrace it?
I think we're using the national language.
Thank you.
Yeah, absolutely.
But combined in that, this is an observation that if we're truly saying we want to be highest point to top of the arts in the way that we're observed, so do we have the ability to use narrative or words like that or statements like that? There's national guidance, but do we have that?
I think it's a good point. I would say, having sat on a lot of the groups, I don't think there is that shift in the NHS at the moment, because the NHSE still are using that ED&I language for everything. But I think it's an interesting challenge.
I think it could be something part of our work as well as we move forward.
That's exactly, I think there's a challenge to us as a team to work out what we would need to do to appropriately use that language. I think we should take that away as part of, okay, so what does that mean next for us? And probably come back somewhere towards the end of the year, end of the calendar year, get a sense of bringing it on in and see how it plugs into the other different bits of work, and then come back to say, okay, this is the plan. Does it start to address the equity issues, not just the big challenge?
Thank you very much, Louise. It's very clear. I don't think any further questions. Alice.
Thank you. This is the formal annual report for complaints and PALs. Obviously, the board sees quarterly report which contain these numbers throughout the year. So it's the formal annual report that we're required to do that sets out the numbers of complaints, numbers of metrics. I think it's probably fair to say, I'll take the report broadly speaking as read, but the numbers are fairly static. What we are seeing, which isn't reflected in this report, is the complexity of those complaints and contacts increase. So we're having complaints, for example, where there are between 30 and 40 questions being asked as part of that complaint. So very complex complaints that are taking a lot of time, and that's being reflected in our response times, because they're having to go on to lots of different teams for that response. One of the things that we're looking to trial to pilot over the next few months to see if it makes a difference is a sort of not similar approach to PSER, creating a kind of huddle response around a complaint when it comes in. So instead of it going off through emails to various different teams of clinicians and members of staff, and everybody then waiting for that to come back via email, that we get the right people in the right place at the same time and say, just as patient or family need a meeting straight away rather than a response in a letter. It's going to take 3 weeks to put together and another 3 weeks to go back and be checked and approved. Is it better dealt with by another means? And can we serve patients better in that regard? So that's some work that is ongoing and will form part of the pilot over the next 3 months, as I said. The issues raised in complaints, again, broadly the same. Communication, which is obviously a huge category, is our main issue raised as part of complaints. And as you would expect, there are some things waiting time, availability. Communication remains that broad, large. I'm happy to take any other questions. There's some breakdowns of where we can see sort of more complaints and others, but we would expect that the high traffic areas and the high use areas for patients. This report obviously comes in isolation, but we also have a lot of other metrics around patient experience on our patient experience platform, PEP platform, which is normally all part of routine reporting to the board. So there's a bit more context around how areas individually are performing.
Questions or comments? Mine's not a clear leading question because you've sort of commented on it a bit, but do you think we're good enough at giving a patient or family a nominated person a one-stop point for their complaint?
I think for complex complaints, that's becoming really difficult. So I think for PALs, for those little routine contacts, the team do that really well. They're able to resolve lots of things very quickly. They're able to to do that themselves. I think increasingly we're getting very complicated complaints that cross over multiple different clinical areas. And so it's very hard then to find somebody who can guide a patient through that process. And we've looked at, models like sort of family liaison style model where we don't have the current resources to do that. But I think as complaints develop and they potentially do become more complex and span different, even primary secondary care interfaces, we all need to look at how we perhaps do that by more easily and give them a better experience of the complaint service.
And is this paper for note? Or is it
Yes,
for approval?
Yeah,
Just
it doesn't need to be.
doesn't need to be approved. And that was the same with the EDI annual report, wasn't it? It doesn't need to be approved, it just needs to be a feature. I think we're receiving that, thank you very much. Thank you very much. So we can move on to the risk management reporting, which I think is you again, Kate.
It is, yeah. So this is a management report. It's a summary report, and then there's some papers and supplementary shelf focus and the board assurance framework. So this report just gives a very high level overview of the risk register, which is in the supplementary shelf with the individual risks. So again, it gives them some risks and some risks where we need to work on our controls, for example, and there's really these are the water note for the operational teams and the organisation to
Which of these cause you greatest concern?
All of them, of course. Without question.
Well, they're static, aren't they? It's a static number, even the number of percentages significant. I don't know if there's anything that is, for any of the execs really.
I would say for me, it's think of what's missing. Where are the risks that are not being managed through this? It's constantly challenging ourselves not to just receive a document and take assurance that we've got all of our risk document is saying, well, actually, where else do we potentially have risk that we need to think about? Yeah, and horizon scanning, looking at the external environment and thinking about what that means for us. So things like rainfall, etc. What does that mean in terms of our own risk profile? And that's an ongoing piece of work for every team.
I suppose a little bit like a conversation earlier in the board meeting about how do we say to ourselves as a board that we're assured that we are expedient enough about responding to risk? I can hear, we can see where we know what we're overdue and within a month, etc. But how do we say, are we pushing that boundary? Are we making ourselves do stuff as expediently as we possibly can? What does that? How do we know that's what's happening, other than by maybe the metrics saying there aren't any yet overdue, but that might be a perfect where I doubt we'd ever get to.
I think it's probably looking at our risk profile and saying, so for example, we've got a number of high risks in footprint profile, risk profile. What's our investment decisions based on our risk profile? Are we looking at business cases based on risk? Those reading through, and is that realistic as well? Are we those risk scores are reasonable?
I was going to wait until the board assurance framework bit, but I think that it might be worth using as an example the head and neck cancer work that Ian's been leading on as evidence of was something like that was static in the actual document on page 100 and whatever it is, 109. There's a lot of work going on clinically to actually reduce that risk and play in. So does that particular risk keep me awake? It's significant, but I also have the evidence about what's going on behind it. So I don't know if Ian wants to come in on that.
So there's a lot of work going on, which I'll reference in part of the board.
Yeah, and I think that might be something that quarterly we reference at board in terms of assurance that we've taken in different sessions, different meetings around some of those bigger risks that we see, isn't it? So that we know we don't just take the report as read within the system. We don't just go, it's about the same amount of risks and some of them are scoring this many. I know that there's a process, but I think it's quite important that publicly we sometimes acknowledge the work that's going on.
So if you come back to, you mentioned fire there. So we had the regional MK fire officer come in to inspect the site, and we had 3 notices that we were required to act upon. That work is ongoing, and we know that we have been picked up in the CQC visit as a query. The place is a bit cluttered. Does that feature in here? Yes. Does fire keep me awake at night? Well, it's higher profile now because of what's been going on in the news over the last sort of 24, 48 hours. And that's in the context of an estate that is at best 2 stories high. So there's a bit of it can appear red here, absolutely, and we might be in trouble with the fire officer if we don't do something about it. But the estate is in relatively good condition, and it's not a high-rise estate. So I think those sorts of challenges every now and again are really worth doing.
Yes, I mean, I think I'm sure if we've read the ground, anybody that's read the ground floor information so far, and I've only read some in pieces, but you know that it's quite shocking and a terrible tragedy for the people involved. I suppose on that point, it talks, doesn't it, about the fire officer not needing to have a qualification in that remit, and I suppose they're the questions that we can ask ourselves about who is looking. I don't mean now, but we can ask ourselves about who is looking after what in our trust.
It might be that we prioritize on our table that we take a risk and follow it through in terms of, you know, actually what does it, as you go down the risk management system in the organisation, what happens, and what information is available. Also information.
Yeah, that was that conversation, but I know we've talked about forums, finance committee, audit committee about some of our risks, about finance, revenue and capital. Our risk appetite on those is now being exceeded or is going to be exceeded over the next few years outside our control. That's what we want to do about those as a board, because we're accepting that, but we're not necessarily actively doing anything about it, and therefore we need to determine how we address that, I think.
I think it's a really good point when you use the word representative. I think when it comes to the October discussion and the objectives, and how are we actively managing which risks and what does that mean? I think that's a really good, both Kate and John. So we've kind of touched a little bit as well into the back.
So the our risk lead, Paul, who you're performing before for viewers, has put together a sort of different kind of, way of looking at the back end in a sort of 1-page summary. Again, all of the details in the supplementary shelf is published online as well. So those members who want to click it is all available. So again, this looks at risk profiling. One of the things that we are doing with the system at the moment with the ICB is looking at how we look at system risk. So when there is a risk affecting every partner in the system, we have all been asked individually to score a risk for our organisation, and then that is being pulled together then to create an idea of risk profile and who's holding most risk at what score across the system around any particular risk. We're piloting it with emergency care. So emergency access. I think it's a really interesting way of looking at risk, and I think it's a really helpful development from a system perspective. I think that's going through the ICB governance structure because it is a sort of an early adopter for this kind of way of looking at risk. But we're engaged in that process, and we'll do some work with them around that because it will help us to surround some of these big issues that have been on our back for a while, and the issue that Jonathan just raised to understand risk within a system context. I think it's a really, really positive piece of work. Otherwise, the back is any questions or also to note.
Questions on the back. I think people have asked before that trend, haven't they? And I think having that summary with the trend, etc. is really helpful, isn't it? If there are any questions, we can have some good discussion, I think, around some of those points, as you say, in the October session, which is what we've planned on the forward plan. Excellent, thank you very much. We are coming to the board committee assurance reports. So we have the Finance Investment Committee report. We have Gary. I'm getting back. Now I'm getting myself confused. No, I am right back. We don't have Gary. But I'm sure we can between us answer anything if there was any summary from. I think Jonathan gave us comprehensive updates around the part of the agenda, and I can't see what I want to see. If there was any questions around that report, but otherwise I think it was clear. Thank you very much. And then we have the Audit Committee report. If there's any comments you'd like to
No take it as read. Just if you wanted me to highlight something, I'd just say the good news about that more. Well, we feel we also have a more robust debt recovery strategy. some issue with salary overpayment. But then particularly good news in reduction in waivers. But generally this is just an update. But from the last board meeting, the one thing I would just put on the radar again is the need to have this conversation about system risk. I'm not sure we've fleshed it out, as I said earlier, at the board level at least. I'm not sure what the answer is, so I'm not volunteering a solution, just saying it's something that, again, just thinking forwards, when someone looks at our organisation and says, what were you doing about this a year ago? We can demonstrate that, well, we were grappling with it then, so we were trying to do our best with a wicked issue.
The audit report. And then the workforce development. I think we did a report for governors recently. I think the recent report earlier has covered much that we do. I just think that we have a really comprehensive and robust process for moving through the pieces of work, but I think therefore we can ask ourselves those questions, such as how do we improve matters that we're trying to do, because I think the workforce team do have a very clear plan to work through the actions through the year to keep delivering improvement. And I think to Precious' point around, we can probably ask ourselves, how do we push ourselves on and forward? There'll always be work to do, and it's not like when we arrive at the destination, go, it's all done. We can set that. So we want to constantly improve both patients and our staff in terms of work. So we'll take any questions on the workforce report. Okay, good. Also, suddenly we're pulling round the time. This was the report. So the forward plan. So the only comment I was going to make on the forward plan here is that Kenny and I talked about it this week, because we were also looking at the thing that governs what we do, Kenny. We're looking at the board structure, how we operate in terms of the terms. And what I've said to Kenny is I think I'm just going to get myself, Kate, 2 or 3 other non-execs together and just have a conversation around those board terms of reference and have a look at this and take feedback really from both exec and non-exec if there's anything. I think for all of us probably looking at it, we just know there's a lot of items here that we have to take. And one of the conversations that we'll begin to have in some groups is around how we can get delegated actions to committees, so the committees can have good, deep, robust conversations and then send assurance to board. So the board, we can have good strategic conversations, both in public and also in our private sessions. So I think that's just a journey of the next 2 to 3 months, really, that we're going to be shaping that out. And I think Helen referenced that in terms of reporting on performance and how we'll do that as we go forward. So I'll take any comments on the forward plan now, but people can always take that away as well and feed in anything they want to say. Nothing more today. Thank you. So I'll move on to questions from members of the public. We have a few. We're going to try and get through them, but also group them together. So I think in terms of staffing in the hospital and understaffing in the hospital, we've responded, and I think we've responded to that question by sending that information back into. We replied last month, but we've added data in terms of the trust vacancy rate being at 6%. We've talked about healthcare support worker vacancy at this meeting. So I think we know that there's an ongoing, but also to give assurance to the public that this is where we would spend a significant amount of time at Workforce Committee talking about this and then be able to assure the board. The next one was on sepsis, and I think Ian was just going to comment back around. So the question is, sepsis reductions in their priority, are the board assured that the sepsis protocols are known and understood across the estate? And someone says, I was prompted to ask this because of the sepsis death in the hospital. I'm aware sepsis can come in with the patient and not necessarily brought in the hospital. And it says here it would be good if the NEDs could explain that as part of the answer. But Ian and I have talked about the information we have, and Ian was just going to comment on that.
So sepsis is indeed one of our safety improvement priorities. We've established a sepsis steering group, which works closely with an existing group called the Care and Critically Ill Patients, and working closely together. I think there'll be three separate streams of work that are important in this area. One is education around sepsis and the specific interventions, sepsis 6, awareness raising. We've got a dashboard, which is available and is used in ED, which essentially lists all the patients who are in the emergency department and describes their news scores, which is a score of physiological status, says whether or not they've had sepsis screens done. It's an important printing copies that are shown everybody in the room. See it, but that's used in ED to make sure that we do sepsis screens at the time. Physiological. I think that the two other important things, really important foundations for the good management of sepsis, is that when patients come into the emergency department, we need to rapidly see that, have a clinician see that patient and understand roughly what category their presentation, rather than having a larger group of range people sitting in a waiting room. The clinician has had a discussion with a patient roughly what it is. Pretty much, we are managing triage patients when they come to the emergency department. Those walking in, we need to do that in 15. And we have dashboards available showing up points in that. So always hit the standard we're looking for. Similarly, on the wards, if a patient deteriorates when on the ward, one of many possible explanations for that is we need, in the first instance, to notice that the patient has deteriorated in appropriate action. So that's again having observations, physiological observations taken at the appropriate frequency based on those scores and or judgment to make response or the escalations appropriate. Frequency of observations or rates. We monitor that through some ward audits that are on a called Tendable. I haven't got that data here, but every month we look at each one, sure that guidance written in policy party committee in those time. That's sort of a summary of sort of the themes of work we do around sepsis.
I think I could the policy committee, noted any points around sepsis, or if there was a sepsis case in hospital, I think that would be a good place for the committee to talk about that. In terms of the patient safety earlier, it wasn't around sepsis, Ian, was it? But around that monitoring of a patient, etc., being timely and right. That's that point, really, isn't it? Of where something would. So then there's a little group of questions on staffing. So the first one is the strategy for local recruitment, as the staffing report mentions international. So I was just going to comment on that, which is within workforce committee again, and the workforce strategy that we report around the international, but we do domestic recruitment continues to have a kind of wide range of ways that we put our roles and our jobs out there to people. And that gets reported to the workforce committee. And then there's a couple of questions around, can you clarify who is employed, including details on consultants, doctors, nurses, grades, physicians, associates? And the second one, which says, do the statistics cover just clinical staff or include ancillary staff? And Louise has got a couple of comments, I think, that she might be going to make on these 2 points, I think.
Yeah, I think this was in relation to the nursing staffing report that we used to Fiona. So I think the first part of the question around the breakdown of the roles, I think we produce a lot of that data through Workforce Assurance Committee. So we go into a huge amount of detail around who we employ and what grade, and they come through committee every year. And remember the second part, Heidi?
The second part was, do the statistics cover just the clinical staff or include ancillary managers, clerks?
So we look at the entirety of the workforce, not just and we break down what vacancy are, what the return over are, but all of those staff groups through the committee.
And I think for any governors who have been asked that question by the public and are sharing that question through through the Council of Governors, or indeed the overall Council of Governors as NID, we can have that conversation, and indeed the exec members can have that conversation around that detail that we do at Workforce Committee, which is where the board can then get its assurance. So And then the last one was about the Denny review. And Fiona, who's not many weeks into role, and has obviously a lot of things that she's already doing, but this is around how are we progressing or implementing this? This is actually in your portfolio, isn't it, Fiona? There'll be a timing, I'm sure, that you want to comment on that.
Yeah, definitely, thank you. So it does sit with me and I have picked up and had a look at it. We will be having some supporting visits working with the ICB in the coming weeks, with some people coming in to look at our facilities and how we support people coming into the organisation. But it's still quite early days for me. Coming in and picking up it is in my portfolio and I'll report back here.
Thank you. Then we had, can the board assure us that doctors on rotation are supported by receiving their rota 6 weeks before taking post? Ian, I think you make a comment on.
Yeah, so this is a requirement of the 2016 junior doctors contract, which was imposed upon junior doctors. Various parts of this contract, but one of them is that they should have 6 weeks of their reasonably of their rota and their rather duties. Generally speaking, we have a very good reputation across Thames Valley of being the best organisation in terms of data. It's in the annual report from the Guardian of Safe Working. It's on 10 days time as well. And I guess the first example I can remember, sadly, was missing that threshold, but it was for one doctor. Where of that requirement standing?
This question, which is about the new buildings and programmes similar to the agreement with Buckingham University to train our own nurses. And I haven't kind of got an answer. And I wasn't quite sure who I was going to field that to, because I think it says, are there programmes similar to the agreement with Buckingham University, doctors, to train our own nurses?
So firstly, just in terms of buildings, the question is a bit challenging.
Yes.
The University of Buckingham and the medical school
Yes.
is New Buckinghamshire University,
Yes.
so they're different organisations. If the question is about buildings, it's important to register that this building is now owned by the trust and is accessible to all, obviously with priority.
I think it's about nurse training and development, but this is not a nurse. We don't have a nurse. Thank you. That's quite a simple word I couldn't find. But I think if that hasn't got clarity in terms of the response and someone wants to come back with one, we are going to send these responses on email, aren't we, in the so we can put a little bit more detail around some of these answers, and then if someone thinks they haven't got the clarity, they can come back. And then the last one was around the HCA role, as it says here, contributing to patient care and safety, is cost effective and releases qualified staff, and plans to fill the large number of the HCA vacancies, which I think we talked about. This is actually healthcare support worker, HCSW, that we talked about in the earlier in the report about how we're working through that. So I hope that we've answered that, and that will also get answered in the written reply. Thank you. It's nice to have a nice set of questions from people showing that they're engaged and interested in what we've got happening here. And I think that brings me to the end of the meeting, unless there's any AOB. Around the camera. So I shall motion to close the meeting and exclude public press, and we bring ourselves to a close, and therefore we will be back here at 1 o'clock for the next session. Wow.